Cancer is just something that we all have to recognize, acknowledge, cope with, live with, struggle with, rage upon, crush, and even thrive with. This show is more than knowing and fighting or beating cancer. It's more than just relaying science, hope, and technology. Together, our purpose is to demystify cancer, take away as much fear out of the diagnosis, treatment, and process as we can, defeat its grip on our lives. This is The Cancering Show. Welcome to The Cancering Show. Today, we're talking about chemotherapy, what it is, how it works, and what patients and their families need to know. Basically, Chemo 101. Whether you're preparing for treatment, supporting someone who is, or simply want to understand more about cancer care, this episode is for you. Joining us is Mary Lucy Mattei, a nurse practitioner in gynecologic oncology at the Mitchell Cancer Institute with 10 years of experience in cancer care. Mary Lucy brings a wealth of knowledge, compassion, and real-world insight from her work with patients undergoing chemotherapy. She's going to help us explore not only the medical side of treatment, but also the practical aspects that are just as important. So grab a cup of coffee and maybe a pen and paper, and let's get into it. Welcome to the show, Mary Lucy.
Thank you so much. I'm so excited to be here.
So we got to talking about this episode because Mary Lucy does all of the chemo education for my patients and all of our patients in the GYN oncology division, and she's great at it. She really helps the patient go from the kind of esoteric, what does chemotherapy even mean, to the very practical, like bring a blanket and a book, knowledge about how they're going to get through that chemo day. So Mary Lucy, kind of tell us what you start with patients and their chemo education.
Well, I think, when they come in first to meet with you, and even if it's after diagnosis, if it's after surgery, whatever it is, and they get your recommendation for chemotherapy, they are probably so overwhelmed that they can't even process anything that you said after the word cancer.
Right.
So, when they get in that room, I feel like it's such a relief to them to sit there and hear it over again. And so really what I do is, when they come in, it's usually, I try to do a 30-minute to an hour visit with them. And they can bring their family members in, friends. It's always good to have another set of ears. Absolutely. And I think they kind of relax and they're able to hear what we have to say. And so usually, I start off very cheerful because, we're going to get through this. This is, a bump in your road, and we're going to tell you everything you need to know. We're going to support you through it. We're going to get you through it. So now let's talk about it. And I guess it depends on, some of our patients are super sick, do not feel well. They are just kind of miserable in the beginning. And so it kind of depends on, are we talking about chemo before surgery or chemo after surgery? And so I think, defining that first, talking about why we're doing it, what kind of cancer they have, even though, you've already gone over that. But, just saying, okay, this is what we're dealing with, and this is what we have to do to get to the end of all this. This is what your road is going to look like.
Right. And I think that's a great place to start, that we define for them why we're doing it, where the surgery, if there is a surgery, would be somewhere along the path, how many doses, how often they're coming. And you're right, we go over that in the doctor's appointment, but too often that still is not in their brain yet. But, just need to hear it one more time. And it differs. Right? For every chemotherapy. And I should say, we are using chemo today as a catch-all phrase, but you guys who've been listening to the podcast know that there's lots of different ways that we treat cancer. If you don't know that, then go back to our previous episodes on things like targeted therapy, immunotherapy, hormonal therapy, etc. But we are using chemo as a catch-all phrase for all of the cancer medicines, and that includes the IV ones and the oral ones, because you can be taking a pill but still have many of the same kind of chemotherapy side effects. So take us through kind of, now that we've kind of defined what the road looks like, where do you start? Do you start with what the day is going to look like?
Yeah, I think I start with, okay, so we are planning on giving you whatever it is. Plan is to start, next week. And so usually I say, okay, so this is the day we're starting. On this day, you're going to get up, you're going to do your normal routine. You have no restrictions. You can take your medicines. You can eat breakfast. You can walk your dog, whatever it is that you normally do. But usually, I tell them, what time of day it's going to be. Usually it's going to be a long day because usually these patients are getting long chemos.
Right.
Especially if it's their first time, just because most of our chemotherapies are long regimens in the very beginning. Mm-hmm. And so I kind of give them that spiel, like what they do, what they bring. So I tell them, you will be here for lunch probably. So you are welcome to bring a lunch in. You're welcome to bring snacks, drinks, whatever it is that you want to bring in as far as that goes. And I tell them, dress comfortably. You're going to be in the chair for, 5 to 6 hours. It will be a long day. Welcome to bring anything in to pass the time, book, computer, your phone. I say most of the chairs have TVs. You're able to watch TV. You can have somebody with you at all times. Y'all can play games. Y'all can, visit, whatever. We also have an art therapist down there that goes, around and kind of helps design art.
And our art therapist has been on our show before.
Yes. And then I tell them that, there are also volunteers down there that have been in your shoes, that have already done what you're about to do. And they're great resources and support. And they're walking around, bringing you snacks and talking with you. And so, that's kind of how the day starts. Right. And then we go into how it goes when you come in. You check into that very front desk. You'll go to lab first, where they'll, start your IV or access your port.
I was going to talk briefly about that. We said dress comfortably, which for me always involves a sweatshirt, and a sweatshirt might not be practical for people who have a port.
Correct. And if they do have a port, I do discuss that part. I, say dress in layers. Button downs are a lot easier. They also make these really cute sweatshirts with the little zipper here
for port
access. Mm-hmm. Yeah, and so we do talk about that too, depending on what they've decided to do as far as access goes. You're going to come in to the very front desk, check in. They'll check you in. You'll have 3 different appointments that day. One's for lab, one's for the provider to see me or Dr. Pierce or Dr. Jones. And then you'll go to infusion. That'll be your 3rd appointment. Just show up for the very first one, and we'll work you through, that. You go to the lab. They draw your blood. You come down to see us. We will have your blood work results there. We will go over them with you. If you have any questions after this visit today, write them down. We're happy to answer them on that day when you come in, or if you just can't wait that long, you give us a call. We can answer anything over the phone. And then, once we see you, we listen to your heart and lungs, we make sure you're doing okay, we'll take you down to the infusion suite. And once you get in the chair, it's usually, depending on what chemo you get, 4 to 5 hours. 30 minutes. It all depends on which chemo that you'll be getting that day.
Right. And talk to me about pre-medications, what that means, what our patients need to know about it.
Yes. So I'm going to use, for example, you're getting carboplatin and paclitaxel, which are cytotoxic chemotherapies that, attack rapidly dividing cells. Your body thinks they're poison when they're in your body, because they are, essentially. And so your body can have a reaction to this. Just like if you were allergic to shellfish, you ate shellfish, your throat can close up, you can have itching, all the different things. So we give medications beforehand to kind of prime your body to keep your body from doing that when we start chemotherapy. So we give 5 different pre-meds. 3 of them are, one's a steroid, 2 are antihistamines, Benadryl and Pepcid, and then we give you 2 anti-nausea medicines as well, because a lot of our chemotherapies can cause nausea, decreased appetite, GI type symptoms. And so one drug is for immediate nausea, meaning that nausea during the infusion, and the other one's for delayed nausea a few days down the road. And so we always give, pre-medications for certain drugs that could cause an allergic reaction.
Right. And so then, and I think you do a good job of covering this with patients as well. So that big dose of Benadryl, a lot of patients are sleepy and might even sleep through a lot of their chemo.
Yes, very true. And so that's kind of what I tell them too. When you come in, you're welcome to bring a blanket, pillow, headphones, eye mask, whatever you want to do to just kind of sleep the day away. The chairs do recline back and kick back, so you can prop up and take you a good long nap, especially after that Benadryl dose.
Yeah. And so then talk us through what you tell for patients at the end of the day. So we've gotten through the chemotherapy. We've been in the chair the whole time. It's time to pack up and go home. What should they expect then?
Well, on that day, you usually feel okay, maybe a little groggy, maybe a little sleepy, but usually you feel good that day, and usually you feel pretty good the next day and maybe even the day after. Could be from those steroids that we give you, but also, the chemotherapy is getting in your body, is starting to work. And then, usually day 3, 4 after chemo might be when you kind of feel the clouds shift a little bit and start feeling some of the side effects of the chemotherapy, depending on what you're getting.
And just go through for us kind of the common ones, how to treat those at home and what to expect.
So, cytotoxic chemotherapy, kills rapidly dividing cells because cancer cells are rapidly dividing, and that's what we're trying to do. But also some of our normal cells are rapidly dividing, and that's why we have some of the side effects, because it affects these certain cells in the hair, in the GI tract, in the bone marrow. And so I think, things to look out for or things that you might expect to feel after chemo is fatigue, for sure. I do think that is the one side effect that's more compounded the more chemo you get. So, the more chemo you get, the more fatigued you're going to be. It's like running a marathon. At the end of the marathon, you're more fatigued than you were when you started. So fatigue, nausea, decreased appetite, aversions to certain foods, taste changes. Some people will get reflux, bowel changes, constipation.
Right. And that's what I was going to say. A lot of people worry that chemotherapy will give them diarrhea, and some chemos do. But much more of the time, the nausea medicines that we recommend to you cause constipation. And that tends to be the problem that our patients are fighting with the most, especially as you get towards that end of the first week, day 5, 6, 7. I think we get a lot of calls about that.
That's true. And I do talk a lot about that. But we do a really good job of keeping you from throwing up, but also a really good job of kind of managing that nausea with what we're doing pre-med wise and what we send you home with. So I do feel like a lot of patients have very little nausea.
I agree. And I think that's the thing that people worry about the most, or that they remember from the 80s or 90s, or even other types of chemotherapy can be more nauseating. But most of the time, we're doing a really good job managing nausea.
Yes, I agree. And I mean, we have patients say, I have had no nausea at all.
Right.
So that is a huge deal.
Yeah. I always tell patients, if you throw up, call us.
Correct.
It seems like, you wouldn't because you'd expect it with chemotherapy. But at the same time, we're only giving you about half of the medications we could give you. So, if you throw up, call, because there's always more we could give you. And sometimes it's not the chemo.
Right.
It could be something with the cancer, or it could be the GI bug that you got from your preschooler or your grandchild.
Yeah. Right. For sure.
Talk to me about what you recommend for constipation, since that is such a prominent side effect.
Well, I first tell them, diet is very important. We talk a little bit about diet, which is a whole nother topic. But, I say anything over the counter can help. Miralax up to 3 times a day, stool softeners, milk of magnesia at night. I had an old mentor that told me no BM in the AM, MOM in the PM.
I love that.
Yeah. So, milk of magnesia at night. And then you can do multiple things if you need to. Now, some people are super sensitive to Miralax. And so I think it kind of all depends on how you are at baseline.
Right.
But a lot of women are constipated in general, you know, so that doesn't help.
And I always tell folks that Miralax is great, but it's using water to push the stool out. So you really have to be very well hydrated.
Yes.
If you're not drinking a lot of water, then a stimulant laxative like a Dulcolax or milk of magnesia might work better for some people.
Right. And I do, say you've got to drink lots of water. Number one, to keep you hydrated and to flush the chemo out, but also with your bowels. So I do tell them, I want you to drink 48 ounces of water a day. And so hopefully if they're doing that, then the Miralax would be beneficial. But also I say this chemo causes you cannot eat, you cannot drink, you just do not feel well. And you've tried all the nausea medicines that we've given you, call us.
Absolutely.
We can always bring you in any day of the week, check labs, see if you're dehydrated, see if any electrolytes are off. We can replete those any day of the week in the infusion suite and help with that. We can give IV nausea medicine in the infusion suite. There are things that we can do outside of things you're doing at home to help with this.
Right. And to keep people out of the emergency room, keep people out of the hospital.
Right.
And I think for our listeners who are not in Mobile, I think that's true of almost every cancer center in the country, that you can manage those symptoms and side effects. Again, we encourage you to kind of think of that on a Thursday afternoon. Come in Friday morning. Don't let it wait the weekend so that we can get you taken care of.
Right. And I do think I tell them that too. Like, give us a heads up if you think, all day yesterday you just couldn't do it. Call us first thing in the morning and say, this is what's going on, so that we can get you in. Because sometimes if we have to replete, magnesium or potassium, that can be 2 to 4 hours long.
Right.
And so, we want to get you in before lunch, and also the infusion schedule, depending on that. But that's always an option to kind of help with those symptoms.
Let's talk about hair loss. We have not done a full episode on hair loss. If you're looking for one, we have done a full episode on nausea and constipation. There's lots more that we can talk about there. We have done an episode on pain control. Let's talk about hair loss, because I know for many people, they're like, it's not a big deal. And yet we know, especially for our women patients, but we know across the board, it is a big deal.
It is a big deal. Definitely the biggest side effect that patients break down on when I talk about it.
Yeah.
And if y'all don't tell them they're going to lose their hair, I get really upset.
That's a really great point. I'm trying to think.
You usually do. But I'm like, did they tell you you're going to lose your hair? And they're like, yes. I'm like, good, because I was going to really get on to them if they didn't.
I get that, because I do think people need time to prepare.
Yeah.
And I do think we, especially when we are in an advanced cancer or a palliative setting, if that is a no-go for people, I want them to know there are other choices. There are chemos that are FDA approved for every cancer where you don't lose your hair. Yeah. So if it stands between you and treatment, then let us know that, because there are other things we could do that would still treat the cancer.
Yeah.
But also, walk us through what you say to patients about it and how to handle it. What are the options?
Right. So most of the time in our GYN oncology cancer world, you are getting Taxol, and Taxol causes hair loss. It also can cause peripheral neuropathy, which I can talk about in a minute. But the hair loss is always a thing, and it's always going to happen if you get Taxol, right?
Yeah.
I mean, they ask that, are you sure? I'm like, I'm positive.
Right.
And what I normally say is it starts thinning out after cycle 1, and it can come all the way out before cycle 2, or it comes all the way out after cycle 2.
Right.
Hair all over the body will thin. Your eyebrows, your eyelashes, hair all over the body. And sometimes as it's starting to happen, you can feel like a tingly sensation or even kind of pins and needles. You might go to the shower and brush it or wash your hair, and it comes out in clumps. And so what I usually say is, sometimes it's helpful to just go ahead and cut it really short so that it's not so dramatic when it starts falling out.
And not so messy.
Correct. And you don't wake up and see all of your hair on your pillow. That's kind of traumatic, So I tell you, you can do that. Get your hairdresser, make an appointment with your hairdresser and say, this is what's going on. Let's cut my hair. Let's do this.
Right. And I do say that to a lot of people. They kind of don't know where to start. And, do they start at the cancer center with a wig fitting or something like that? And I usually say start with your hairdresser, but also know that we have a resource room where you can try on wigs, where there are actually wigs available for free. And it's a good starting place, because then you might decide you would prefer to spend a little money to get something of a different quality or not. For some people, what we have available or what's available inexpensively is just fine.
Right. And I will say too, some insurances cover wigs. And so I, always talk about cranial prosthesis, and I can give an order for that, and your insurance, a lot of insurances will cover that for you.
Yeah. And a lot of people prefer not to wear a wig.
Rocket bald.
Yeah. Baseball hat, scarves.
Big earrings, red lipstick.
That's what I say too. Yeah. And so do you want to talk a little bit about our recent new relationship with the tattoo artist who's helping women?
Yes. So Outliner Studio is a permanent makeup company, and they have been doing, eyebrows, eyeliner, lip tint, but they also do nipples for women who've had mastectomies for breast cancer. They can do this nipple tattoo that looks so real. It is even like 3D looking. It's amazing. And so I had a patient recently who said, I'm of course okay. I'm going to be okay with losing my hair. That's just, I've come to grips with that. But I would like to do something else to kind of help me feel like a woman. And eyebrow tinting. So micro shading, I think is what's micro shading. Is that what it's called?
I don't know.
I think it's called micro shading. And it's a little tattoo that they do on your eyebrows.
To make it look like real eyebrows.
Real hair. Right. Mm-hmm. And so I called the company, went out there, met with them, and kind of talked to them about, what our patients experience. And they are all excited about possibly helping out some of these women that are, going through this.
Right. And I would say, again, for folks who are not in Mobile, there are lots of companies and tattoo artists who offer this all over the country, but do make sure it's somebody who specializes in these particular tattoos. You wouldn't go to just any tattoo artist and ask them to tattoo in your eyebrows.
Correct. Yep. And I will say this too. What do you think about the timing of doing this for patients? Because usually when we are recommending chemotherapy, we're starting quick.
Right. I would say when it's thin but not gone. So, when we are getting started, it is a little bit of a rush and those appointments are bundled together. But most chemotherapy, there's a 3-week break between doses. And in all honesty, I know people don't expect this. You feel better after cycle 1 than you did before cycle 1. That's often why we're rushing, because the cancer is what's making you sick.
Right.
And killing the cancer makes you feel better.
Right.
So a lot of this stuff that we're talking about, there's not necessarily a rush to do it after the first dose, but really between doses 1 and 2 is a nice time to just take a moment and think about, what am I going to do about my hair when I get to that dose number 2? And it mostly comes out. What am I going to do? Would I be interested in tattooing for artistry? A lot of times that's when we do a port. Right. We'll do an IV for the first dose, but then we'll put in that port before the second dose, because that is an outpatient procedure that requires some time to heal from. So a lot of people think that all of this has to be done before the first drip of chemo into your body, but that's not really true.
Well, I think the artists there are worried about infection. And so I think that's kind of the question that they have for us.
Right.
Because they want a doctor's note to make sure it's okay to do it if they've started chemotherapy, especially just because of risk of infection.
Sure. And what I would say to them and to our patients is there is a risk for infection, like fatigue. That risk increases the number of doses that you get, because just like we were talking about with everything, the compounding effect on your bone marrow, the risk for low blood cell counts increases with each duration of chemo. So most people are not going to have a critically low blood count after dose 1.
Right. And we're watching these blood counts. And so we're going to know before every cycle, every 3 weeks, what you're doing. So I guess as far as that goes, then you feel like it is safe to do it.
Absolutely.
At any time, really. Mm-hmm. I mean, maybe closer to the next cycles or all that. But
right. And we've talked about that briefly on this show before, but a lot of people wonder when's the best time to do X, Y, and Z, even if they're planning a birthday party or whatever. It really is close to the next dose, not in the middle.
Right, because your blood counts start dropping after chemo, and they're there at the lowest day 7 through 10, right? So that week to 10 days after chemo is when your blood counts are at their lowest, and we don't know how low that is. We're not going to check them at that time. That's just something to keep in mind. Maybe be a little bit more cautious during that time frame. Maybe don't go get tattoos then.
Right. And then they come back up just in time for the next dose.
Correct.
So that's in that third week that we would recommend doing all these things.
Yes, like a port and any of that kind of stuff.
Right.
I was just going to say, we were talking about hair loss in general. there's a lot of question about cold cap.
Yes, let's talk about that.
And, it's hard. We give Taxol over 3 hours. That's part of the issue with maintaining what you have to maintain with a cold cap for that long.
Let's talk about what a cold cap is and why 3 hours might be a long time.
And it's not just 3 hours. You have to pre-freeze and post-freeze. So it ends up being like 5 hours of having a cold cap on your head. So and maintaining that temperature that it needs to be successful at keeping your hair from falling out.
Right. So just to recap, this is actually a physical machine, like
Correct.
An old hairdryer, but it is applying very cold air to your head while you're getting chemotherapy with the hope that that decreases the amount of chemo experienced by the scalp, and therefore your hair is less likely to fall out. I have seen amazing success less than 10% of the time, and I have seen some thinning compared to full hair loss most of the time. But as you said, it's a very small number of people who are willing to go through that level of discomfort to preserve hair.
Right. Especially in our world. I feel like the breast cancer world is better at it. Maybe because they're getting weekly Taxol, which is not as long.
Right.
It's usually younger patients, I would say.
I think it's the length. Yeah.
Yeah. I really feel like cold capping is more successful when you're getting a shorter duration of that chemotherapy.
Right.
It's very difficult to keep the temperature where it needs to be for that long. We had a young patient do this all in, did all the things you're supposed to do, and she still lost her hair, which is, very disappointing.
Yeah. So just know that that is an option that you can review with your oncologist, nurse practitioner, or your infusion nurse at length if that is something that you would like to research more. Mary Lucy, anything else you would want to add? I know there's so much more we could say, but we do want to keep the episode to a reason. Let's
talk real quick about the neuropathy portion, because that is also a big deal. But we also do a really good job of preventing it because we give the Taxol over 3 hours. So it's very slow. And we also recommend something similar to cold capping, holding ice packs on your hands and feet during the actual Taxol infusion. And we have had a lot of success with that. Mm-hmm. Lots of folks, do well without neuropathy throughout their chemo. Now, of course, sometimes it's painful and hard to keep them on there for that long, especially with women that are little tiny things and they're always cold, or if they have Raynaud's or, whatever it is. So that has been a huge success, I feel like.
Absolutely.
But it is an issue. It does affect people. And I will say it presents differently than just numbness and tingling. It can be pain in your extremities and in your legs, especially, and this aching, throbbing pain. And so, there are things that we do to help with that. Claritin is an antihistamine that kind of blocks that and kind of keeps that bone marrow from causing, going overboard and causing that pain. And so we use that a lot of times. And then also we use, Tylenol, ibuprofen. Some people have it bad enough to need a narcotic.
And specific pain medicines for neuropathy, in addition to the ones that you mentioned, I totally agree. And we want to know about your neuropathy, especially folks who have baseline neuropathy or numbness of fingers and toes related to things like diabetes. We want to know ahead of time because we might even adjust
the Taxol to a lower dose. We might start off at a lower dose for those folks, for sure.
Anything else?
I mean, I could go on, but I think that's the basic, lower blood counts than normal, GI symptoms, hair loss, peripheral neuropathy, fatigue. Those are basically the ones. But we want you to live your life and do the things you enjoy and keep living. And I think, to say, carry on with what you're normally doing so that you are able to, get through this as you would a normal day. I think keeping to the same routine is very important emotionally, and it just kind of helps you get through it.
Yeah.
And not focus on that.
And I think one of the questions I get a lot is for patients who are working, do I need to take the entire 6 months off of work?
I do not think so. I mean, people that work want to work, live to work. It gives them a purpose. I think it also takes your mind off of what's going on. And I think it's beneficial to continue working. Of course, with in mind, increase your risk of infection you have with chemo. You've got to just be a little bit more cautious about that. But I say go for it. Yeah. If you need a day or two off, take it. But live your life and do the things you're meant to do.
Right. And there's all kinds of ways that we can help you negotiate that or navigate that with your work. If they don't have an HR, we can help with paperwork. If you do have an HR kind of more formal process and you need to do that intermittent short-term disability, we can help with that too. So there's a lot of options, but most of the time we're going to encourage you to keep working.
Yeah, I agree.
All right. Thank you so much for coming in the studio today, Mary Lucy. It's so fun to have you here. And I know this is going to be really helpful to our patients and to patients all over the country who don't get the same level of attention that you give to our ladies.
Well, I enjoyed it. I'm glad you asked me on, and we're going to help y'all. We got you. We're going to be your support system. You can do it.
I can't think of a better ending than that. You guys had such a treat to hear Mary Lucy's chemo education. She is an expert in getting patients through chemo. And just like she said right at the end, we got you, we got this. And I hope you felt that reassurance. I know not all of you get to work with Mary Lucy for your cancer journey, but I know your team feels the same way. Depend on their expertise. Call them if you have questions. Don't be afraid to ask a question. Don't assume that throwing up is part of the gig. And we will get you through this. I hope this discussion was as informative for everybody else out there who maybe is not cancering, but taking care of somebody who is cancering. Keep in mind, if you have any follow-up questions, we'd love to hear from you, and we can address those in a future episode. Just go to cancering.com and submit your questions there. Until next time, keep cancering and take care of yourselves. Thanks again for listening. And don't forget to submit your questions at www.cancering.com. We're here for all of those questions and we'll get you the answers. This show is brought to you by the University of South Alabama Mitchell Cancer Institute. MCI is a cutting-edge cancer research and patient center built to fight cancer smarter in Mobile and Baldwin County, Alabama. Our researchers and clinicians focus daily on the struggle against cancer, serving a potential catchment population of more than 4.1 million people, with a singular focus of advancing cancer diagnosis, treatment, and prevention throughout the Gulf Coast and beyond with science, technology, and hope. Want to know more about the Mitchell Cancer Institute? Visit us at usamci.com or search for us on Facebook, Twitter, and Instagram. Mitchell Cancer Institute is a member of USA Health. To learn more about all of our hospitals, clinics, and services, visit usahealthsystem.com.